Pawan Ojha, our third speaker for the session. He's a consultant neurologist and he is well known in the stroke circles. He is affiliated to Hiranandani Hospital, Vashi, a Fortis Network Hospital. Today he is going to speak to us on viral vasculopathies and stroke. Over to Pawan.
Good afternoon, everyone. Glad to be a part of this great meeting. I hope I'm audible and visible.
Yes.
Yeah, you are.
So I'll start sharing the screen now. Host has disabled my participant screen sharing. So I can't share the screen. Can someone help me with that?
Yes.
Can someone from the organizer help them with these slides?
Yes, sir, we are on it, sir.
Thank you.
Yes, on screen share.
Yes, now it is. Yes.
Yeah. Your slides are visible now, sir.
Yeah, I'm just wanting to move this slide thing. Yes. So many thanks to the organizing team and congratulations for hosting such a beautiful online conference and summer school. My topic today is very relevant for the time, and that is viral vasculopathies and how they cause and when they cause strokes. So let's go with it. So just as a brief introduction, I would like to make a mention that stroke can occur during or after infection with the viral infection or any other infection for that matter that we'll see. And it can cause both ischemic and hemorrhagic stroke. Now, what are the proposed mechanisms? It's very simple to understand that well, it could have caused some vasculitis or some procoagulable state, but there are other mechanisms as well which one needs to understand and keep in mind. Now, which all infections that we know of which cause routinely some strokes, that sometimes it can be tuberculosis, syphilis, fungal infection that Dr. Rahul had spoken, and some bacteria, obviously. But most of the viruses that we know, they don't cause stroke directly, other than few that we will discuss today. And some of these infections, if you have a preceding infection like a UTI, maybe in an elderly, or some chronic infections like chlamydia or H. pylori, they do enhance the risk of stroke. And how and when do we suspect it? So if there is a person who has a clear-cut viral illness and he develops a stroke, I mean, no brownie points for guessing that the virus would have triggered the stroke. But there are those patients who have stroke and you're just wondering what has caused it, and it's an unusual stroke. And when you see some of these telltale features on the MRI or on the CSF, or in terms of history taking, like there was a rash which was forgotten some time back. So there are these features which one should remember, that in acute stroke, if you have a lot of headache, seizure, stroke-like events, definitely then one must keep in mind an infectious vasculopathy. Also, wherever we think of a primary angiitis of CNS or a multiple sclerosis like presentation in the MRI, then one must keep in mind infectious vasculopathy as well. So with these brief things, we will go directly to viruses and stroke. So many of the viruses which have been implicated, they are like the ones like varicella zoster virus, HIV, Epstein-Barr virus, and so on. But probably the most important one before coronavirus came in was varicella zoster virus, and there is a lot of proof that it causes direct involvement of the blood vessels in the brain. Now, stroke can definitely occur even weeks or months after the infection. The highest risk of stroke is obviously with ophthalmic zoster and the virus causing a transaxonal spread to the ganglion to the cerebral arteries and then causing a stroke. However, in some of these patients, they have identified that there is a transient presence of APLA and some antibodies to the coagulation protein. So as very well seen as the deficiency of protein C and protein S during that state, which might have contributed to the stroke. So that is very important to keep it in mind and probably actively look for it as well. Now, in COVID-19, what we have understood is there is a more of a hematogenous involvement rather than a direct neuroinvasion, but obviously we'll go through all that little later. Now, let us try and understand and what are viruses, how they attack our systems, and what are the defense mechanisms to understand what is this whole fight and how the stroke comes. So these viruses are basically obligate intracellular organisms which don't have a mechanism on their own to replicate. So they use the mechanisms of the host to replicate in most circumstances, and they replicate in those host tissues which have specific viral receptors. So almost everyone knows now that there is ACE2 receptor which is important in COVID-19. So there are similarly other receptors which are important. These receptors are there on the host cells, and so that these viruses can attach over there, and depending on where they attach, what happens, the symptomatology ensues. Now, so these viruses, they have what is called as a pathogen associated molecular patterns, and these patterns are detected by the host pattern recognition receptors, and this allows the detection of the identification of the virus by the body and differentiates it from the host cells. After this identification, then there is a release of interferons and many other cytokines which can cause viral clearance in some time in most of the individuals. Now, two types of immunity are important in terms of virus handling. First is innate immunity, which is by polymorphonuclear leukocytes as well as monocytes. And second and most specific is the adaptive immunity by the T and the B lymphocytes. Now, this is in general in the body, in the systemic field. Whereas in brain, the scene is a little different. That we have the fight with the virus in which the microglia, astrocytes, as well as neurons all participate together and fight with the virus with the help of the immune cells which come out from the blood vessels. Now, since the fight is there, so that is why there can be a virus vasculopathy as well. So what happens is, it's very easy to understand that the virus must have attacked the blood vessel and direct angioedema, but that is almost never the scene. There is a combination of many factors, that is the general body inflammation, systemic inflammation, or a specific blood vessel inflammation, then hemostatic mechanism and metabolic disorders of blood vessels. So all these disturbances, they can work hand in hand and get the situation out of control. So as it is also seen that one more mechanism can be there as seen in CMV or HCV, is that there can be an immune complex deposition or a T cell infiltration in the endothelium. Now the blood vessel is in three parts from out to in, that is adventitia, media and intima or endothelium, which is in throughout the body. But obviously the adventitia is missing inside the brain, and the inflammation of the blood vessel can the antigen of the viruses can be seen from outside to in, as in case the maximum antigen is deposited in the near the outer adventitia, and whereas the inner part, the hematogenous spread viruses can attack on the inner part. So these things can cause a inflammation of the endothelium, which is the endothelitis, or inflammation of the whole blood vessel wall, which can change its shape, its contour, and make it prone for rupturing of the plaques as well as an aneurysm formation. This can also, these viruses can also destabilize the cardiovascular condition of the patient. So not only the heart may start having a myocarditis or weakness, or there can be arrhythmias, and there can be hemodynamic instability, dehydration. All these factors might contribute to development of stroke. Now let us look at these factors one by one. So the direct invasion of blood vessels, although it's very important, how does it happen? So the viral components, they bind to the endothelial cells. Other than that, there is also activation of the adhesion molecules. These adhesion molecules are important in binding the endothelial cells to the undersurface as well as in between themselves. There is also release of pro-inflammatory cytokines, and all these things, they lead to the roughening of the endothelium as well as sometimes formation of mycotic aneurysms wherein the hemorrhages can take place. Other than that, the viral infection can also induce inflammation in the vasa vasorum, and it may accelerate the atherosclerosis, or it can destabilize the existing plaques. So this is another interesting theory, that why do the plaques, they destabilize versus why do they get accelerated? How does the acceleration of atherosclerosis take place in terms of infection? In viruses which cause the hepatitis, there can be an immune complex deposition in the vessel wall, and this can also cause vasculitis. There are also in varicella zoster virus, they found that the autoreactive T cells have been found in giant cell arteritis. So, but this still needs some more proof. But just to keep that in mind, that these autoreactive T cells may be present in giant cell arteritis biopsy samples. Now, not only this direct vasculitis, but sometimes there is also an indirect vasculopathy that depends on the ACE level. Now, this ACE level, ACE2 is important, that it degrades the angiotensin 2 to angiotensin. Now, this angiotensin has a wonderful properties of vasodilatation and antithrombotic properties. So now, once the because of this COVID viral infection, the angiotensin level is reduced. So there is some vasoconstriction as well as a pro-inflammatory state and thrombogenesis. Not only this, there can be also autoantibodies found against ACE2 levels that also leads to further vasculitis. Now let us also talk about this inflammation and the atheromatous plaque theory. And all this we already seen that the inflammation may generate atheroma. The viral infection can destabilize. There can be a degradation of cap and a plaque rupture. Now this is very interesting, that systemic inflammation may result in dynamic expansion in cholesterol. When the cholesterol is crystallizing, there is a dynamic expansion of the cholesterol, and this may cause a sharp crystals which may perforate the fibrous cap. So why does the fibrous cap rupture? This is one proposed mechanism. Other than that, the release of cytokines and proteases, they sort of have a degradation effect and direct thinning effect on the plaque. Other than that, there are few other things that one must keep in the mind, that is hypercoagulable state or procoagulable state, thrombosis, and how it is seen in case of a viral infection. So the viral infection as such can cause platelet function abnormalities, activation of the coagulation system also. Now, once the platelets are activated and they are aggregated with the leukocytes, they can cause a release of fibrin, and this causes the thrombus initiation and growth. Now, there is also a release of the tissue factor, and also decreased levels of protein C and protein S are seen in the blood around the thrombus. Another factor we discussed was the formation of APLA transiently in patients. Now let us see which are the respiratory viruses which could cause this kind of situation where there is an endothelial cell activation and procoagulable state. So the influenza virus, parainfluenza, adenovirus, and herpes virus. So it is also very important to note that the adenovirus has been used in Covishield vaccine. There are other mechanisms which can cause secondary strokes in viral infections. Other than what we already noticed, that these hypercoagulable state, metabolic and hemodynamic derangements that are occurring with the sepsis, they may induce hemodynamic fluctuations in patients. Those patients who have got poor vasomotor reactivity, who got bad cerebral perfusion pressure, if there is some fluctuation in the hemodynamic status of the patient, along with sepsis, hyperglycemia, dehydration, etc., they are also very important. So disruption of the daily prescribed medications in the state of the viral infection, many times patients discontinue their prior medications, that they're using many other medications. So that can destabilize their comorbid vascular conditions. Sometimes the over-the-counter medications which are required to treat these kind of infections, like sometimes vasoactive drugs, nasal sprays and other things, they can also aggravate the situation and predispose towards the stroke. So overall, in the presence of a baseline vascular risk factors, atherosclerotic disease, and these physiological challenges, they also might contribute heavily to development of stroke. Right. So when do we investigate for viral causes of stroke? So sometimes these viral causes of stroke may be misdiagnosed if lumbar puncture is not done. That is one strong clue, that if there is a pleocytosis, then one could think of an infection as a cause of the vasculopathy. The other thing which could be used as a clue are presence of fever, antecedent fever, rash, known prior infections, immunocompromised state like patient having an HIV or other immunosuppressant use. One should strongly consider viral causes, viral vasculopathies, and meningeal, if there is a meningeal enhancement or infection, then one should think about it. So treatment wise, The only antivirals which are available for VZV as well as CMV, and sometimes steroids might be of some use. So this is a broad classification of the viruses that is available, and one must know the classification in detail. So this is something about the varicella zoster virus, that it spreads to the arteries in the central nervous system and can cause both hemorrhagic and ischemic complications. There is one slide regarding this. So there can be superficial and deep infarcts in the varicella zoster virus infections, and especially at the gray matter junction. So this I want that everyone should remember that if we see some things like this, then please think about varicella zoster as one possible cause. And negative angio can be seen, and pure large artery disease is actually rare. There is usually a combination of small vessel and large vessel disease in this. Then usually the CSF is abnormal, and only negative results in both VZV PCR and anti-VZV IgG antibodies in CSF can exclude the diagnosis of VZV vasculopathy. In one study, CSF anti-VZV IgG antibody was seen in 93% patients, whereas the PCR was positive only in 30%. So that is a point to remember, the CSF IgG. There are many other viruses that can cause these infections and stroke. So HSV2 can also cause this stroke. And then CMV infection is more common in immunocompromised individuals, and vascular changes are also seen in solid organs after transplantation. But there are further studies are required whether this can also induce atherosclerosis, as there have been some suggestion like that. And we also know about HIV vasculopathy. These patients of HIV, they rarely get stroke if they have no concurrent other opportunistic infections, lymphoma or embolism. So per se, HIV causing stroke is rare, and it has been found only in about 5% of cases. And the HIV vasculopathy is identified as highly in small vessel thickening, perivascular space dilatation, vessel wall mineralization, and perivascular infiltrate. So direct invasion of vessels is not shown in HIV. Probably these are all VZV co-infections because the antibodies were not tested in the CSF, so it cannot be concluded. This is why in one of the articles it is mentioned like this. Right. So the chronic HCV infection. Yes.
Can we conclude that we have some interaction? Otherwise, we may not.
Yeah, actually, how much time is remaining? Because I can't see the time here. Somewhat, I just can't see the time. So, how much time do I have?
Pawan,
Yeah.
Pardon
time
me?
is up. We
We
just
have
have 4 to 5 minutes for discussion. We can take a couple of
Yeah,
minutes more.
yeah. I'm just finishing. Yes. So, in the hepatitis C, there is incidence of cryoglobulinemia and deposition of immune complexes in the vessel wall, and this can also provoke the atherosclerosis. But it's important to know that many patients with HCV and stroke, they did not have liver disease. So it should be kept in mind even when the disease is not having a liver component. Now, there are a lot of this discussion about COVID related stroke, and many of us have also seen, suspected why it is happening. Now we've all become very wise, and probably the COVID itself has brought out the viruses and interest in them. So there are a lot of various types of stroke, small vessel, large vessel, and about 1/3 to 40% of patients will have some large vessel component, intracranial component. So there are few studies which I would like to bring out, that out of 214, these patients who had neurological symptoms were 88, and only 6 had stroke in one study, 5 ischemic and 1 ICH. So this is roughly the pattern. And of the another study with 221 patients, only 13 had stroke at a median of 10 days after infection. So there are those patients who have these elevated D dimer, and you are scared, and most of us now give low molecular weight heparin and other neuro-oral anticoagulants. And no need to tell this august audience about all this ACE2 receptor thing and inflammatory cytokines and procoagulable state which cause stroke in COVID-19. But the possible explanations other than the direct infection are the worsening of cardiac function or arrhythmia in these patients, down regulation of ACE2 receptors, prothrombotic state as is noted by D dimer, and sometimes patients have APLA and protein C and protein S deficiency. But the neuroinvasive potential of SARS-CoV-2 is recognized but not proven. This is to be kept in mind. That so another condition is endothelitis. We will all be hearing about it, and there is an intense cytokine activity, heightened inflammation, and dysregulation of the thrombotic balance, and the destabilization of plaques in these patients, and increased levels of D-dimer. Now there are some reports of positive antiphospholipid antibodies in these patients and causing stroke. So endothelitis as well as vasculitis could explain why some of these patients they get ischemic stroke, hemorrhagic stroke, or both. So that could be one reason. And there is only one case of acute meningoencephalitis with COVID-19 where it was documented as neuroinvasion because the CSF showed PCR positive while the nasal swab was negative. So in coming to the conclusion, in the take home, what we have is that the importance of viruses causing stroke has been highlighted by the COVID-19 pandemic. So we are thankful for increasing our understanding about viruses and how they cause stroke. Further work needs to be done. Pathogenic mechanisms are still unclear, and viral infections can affect both the periphery, that is the viral infection in the body, and directly in the CNS. So both can cause strokes. Viral infection outside the brain, that is in the periphery, can cause stroke by systemic immune activation, hypercoagulability, endothelial dysfunction, or formation of thromboemboli. And only the herpes viruses are really shown to have invaded the CNS vessels, but some component of systemic immunoactivation also is possible. So with that, I come to the end of the talk, and I'll stop the share screen.
Yeah, thanks, Pawan. That was a nice presentation. Rohit, if you permit, we'll allow one or two questions from the
Yeah,
audience.
so
Any
Sir,
questions?
we can have one or two questions, sir.
Yeah, fine. Anybody? Anyone from the audience, please?
Good evening, sir. This is Dr. Sunil. I have a question for Pawan.
Yes.
Very good exhaustive review. Just wanted to seek after this review, what's the opinion, what is his opinion, and also of the other panelists, on the role of an acute infection in precipitating a stroke in otherwise a person with various vascular risk factors, including carotid disease or other atherosclerotic plaques, etc. What is the what's the role of an everyday stroke? What is the role of viral infection in an everyday stroke as a trigger or a precipitating factor?
It's a very interesting question. I think this is the burning question actually, that most of these patients who we have seen in COVID also, they have some underlying pathology. So it is not like that they are naive, and they are usually elderly, middle-aged and elderly people, and a lot of work still needs to be done in that scene, even when we go out of the COVID pandemic. And personally, I feel that most of these strokes, if you ask them in 1 or 2 weeks or 3 weeks prior, they had some incidents, and that is why they get the stroke. But again, it is open to discussion.
Because people have actually looked at chlamydia, etc., and carotid, but are they the preferred agents to look for, or couldn't there be more common or more?
So chlamydia, as I discussed in my previous opening few slides, that obviously chlamydia, H. pylori, UTI, they cause some inflammation, but whether they cause a direct inflammation in the blood vessel or, just aggravation of the risk factors. But one thought that is aggravation of the plaque, the atherogenesis versus a plaque destabilization. Those things are, I think, they still need some more work rather than just, but the other way of doing it is to do a large epidemiological study and find out, which is also
I think most of the inflammatory markers are non-specific and they are in low titers. And so to establishing that effect is very challenging.
Yes.
Epidemiologically and even scientifically, biologically also.
One, there have been number of studies to show that influenza and being admitted in the hospital for a viral infection like influenza increases your risk of stroke. And by giving influenza vaccine, the risk of stroke comes down.
Yes, right.
Now, it is my personal view that COVID is a trigger as well as a risk factor for stroke, because we have seen people in their 20s also getting stroke, and some of them have had large carotid thrombi, and there's no underlying atherosclerosis. There is a thrombogenic potential, and venous thrombosis has also occurred in many patients with COVID. So there is some thrombogenic potential, and infections also are a trigger for stroke.
So just quick comment regarding the influenza thing. When I was reviewing, the odds ratio of getting a stroke after influenza versus COVID, the odds ratio with COVID is 7.6 times. So COVID is much more,
Yes. There's no doubt. But even influenza is higher than control.
Yeah, no, that is fine. That is fine. But the number of patients that they get influenza in the year, according to that, the stroke definitely is seen less. But the number of people that who got with the COVID strokes is very large.
Yes. So that is why I'm saying it is a trigger as well as a risk factor. It's not only a trigger. That is my personal view. I don't know how to prove it.
No, I understand what you're saying, but absolutely there are those patients out there who you don't identify risk factor. But probably, while I was reading about this, that we are not doing so much of APLA, we are not doing so much of protein C, protein S deficiency. So all those points, if you see, then you wonder if we will ever conclude, because then you will have to do everything in all patients.
No, but at least we are doing D-dimer now in many of them.
So the
D-dimer is a marker. In a way, it is a marker. It's not a very good marker, but other inflammatory markers are also there, like C-reactive protein and ESR and ferritin and all that stuff. So,
Pawan, do you have the odds ratio for herpes zoster and varicella zoster?
I don't have the odds ratio for that, but I have the figures.
Right. Okay.
So I have the figures for that. That if one there is of all the chickenpox infections or the herpes zoster infection. I mean, I'll talk of chickenpox in children. 1 in 15,000 patients of chickenpox rash will get stroke. So that is the figure for in children. But probably it is less than 1% in herpes zoster that they will get a stroke. So that is the difference.
Pawan, I want a little clarification.
Yes.
Suppose you get a child with a stroke and you find that the MCA is narrow and the varicella antigen antibody or whatever antigen is high.
Yes.
Antibody. Should one treat these patients with acyclovir, or how should one manage these patients?
Yeah, so there are recommendations on this. These are class 3 recommendations. So experts like us, they tell.
Pseudo experts like us.
Pseudo experts. So they tell that you should treat this patient for 2 weeks IV acyclovir, 10 to 15 milligram per kg. And the other recommendation is oral prednisolone 40 milligrams OD for 5 days.
Okay. So even if they have no rash, this clarification, very nice that you told me this, because I was always a little confused and, didn't know exactly how to manage.
No, it is there. It is there. This recommendation, but this is a class 3 recommendation, sir. Level 3 recommendation.
So we need to
close it, yeah.
Yeah.
Sir.
Thanks so much.
Right.
Thanks for that.
So we need to close.
Yeah. Thanks a lot, and I thank Rohit and Padma for giving us this opportunity. Thank Nasli for sharing the stage after a long time together. And I thank all the 3 speakers who did a yeoman job in covering the topic in the limited time that was allotted to them, and the audience for interacting interestingly on the 3 topics. With this, we come to the end of this session, and I'm sorry for delaying it by 5 minutes beyond the scheduled time. Thank you.
Thank you, everyone. Thank you.
Thank you very much for closing this session, everyone's participation. We take a short 10-minute break, stretch ourselves, and we are back for the student session. Thank you very much. 4:30 p.m. sharp.